Hypermobility is often dismissed as simply being flexible, but for millions living with Ehlers-Danlos syndrome and related conditions, it can mean chronic pain, joint instability, autonomic dysfunction, and years of searching for answers in a medical system that doesn't always recognize what it's seeing. My guest today is Dr. Marcia Perretto, a doctor of physical therapy and the founder and CEO of Actify Physiotherapy and Wellness in Boca Raton, Florida. Dr. Perretto specializes in hypermobility disorders, including Ehlers-Danlos syndrome and hypermobility spectrum disorders, along with the multi-system complexities that often accompany them: dysautonomia, POTS, mast cell activation, chronic pain, and upper cervical instability. She is the author of Unlocking the Secrets to the Hypermobility Puzzle and speaks nationally and internationally on hypermobility-informed assessment and treatment. Dr. Perretto is frequently sought out for second opinion consultations on complex cases, and she herself lives with hypermobile Ehlers-Danlos syndrome, bringing both clinical expertise and personal understanding to her work. In this conversation, we explore what Ehlers-Danlos syndrome actually is, why it affects far more than just the joints, and how collagen dysfunction can impact everything from the cardiovascular system to the gut to the nervous system. We discuss why so many patients go years without proper diagnosis, the critical role of graded movement and nervous system regulation, and how to replace fear with freedom through safe, predictable movement experiences. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. Experiencing back pain again after lifting groceries, shoulders screaming after a good game of pickleball, even after working out in the gym for the past 6 months? How can you improve the control of your newfound strength and mobility? Strength and mobility should be experienced simultaneously and naturally. Polestar Pilates teachers are taught the principle of control and its relationship to strength and mobility. Looking to move efficiently with control? Find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. If you're ready to begin your own training, go to the Polestar Pilates website, choose your course, and use the code Dr. Brent, the code DRBRENT, to receive 10% off your tuition. And now, my conversation with my colleague and friend, Dr. Marcia Perretto. Good to have you today on the podcast, Marcia.
Hello, Brent. Thank you for having me. It's a pleasure to be here with you again. It's always incredible what we can do together. I'm very excited for today.
I just have to say, I think you're way ahead of what's out there in the literature. I know that you stay very up to date on it, but going through it and just thinking of what I know you're already doing, Marcia, it's just great to have you here. So I thought we would start with a little bit of just, providing some definitions for those that are observing. And again, the purpose for us is to not only educate fellow professionals, but more importantly, our clients, our patients, our community that are receiving these diagnoses. And a lot of times, both the clinicians and the practitioners aren't familiar with it enough to be able to provide clear direction. And also, our community at large is not able to do that. So there's a lot of people that go years before they finally get diagnosed properly and receive the proper care. And you and I both fall into that spectrum, so we also know what it's like being in the hypermobile spectrum?
So I think the first thing we have to remember is that Ehlers-Danlos syndrome by itself, without any other letter in front of it, it just talks about 13 types of a specific syndrome that causes hypermobility. So there is like 13 types of them, right? One of these types, then it's like, think of an umbrella, and then you have lots of different syndromes falling underneath. Then you have hypermobile Ehlers-Danlos syndrome, which is the most common. It's estimated now that 1 in 500 people can actually present with the syndrome. And we don't know what gene. So out of the 13 types, 12, we know what gene causes. So we do a genetic testing. It's going to come positive, and it's going to say it is classical Ehlers-Danlos syndrome, classic-like Ehlers-Danlos syndrome, vascular Ehlers-Danlos syndrome, and etc. But the hypermobile Ehlers-Danlos syndrome, we still don't know what gene it is. There is a little bit of like coming up now, but it's still not certain.
And when we talk about Ehlers-Danlos, I mean, let's even back up a little bit of this umbrella. Let's explain this umbrella a little bit, because I think it's overwhelming even for us as clinicians to try to understand what it is that we're seeing and what is it that it's genetic, what thoughts on it being caused by environmental triggers of something underlying genetic. So tell us a little bit about like where does it, and I think it's just been in the last how many years that there was even a classification system that was really specifically like last 10, 15 years. It's pretty recent.
Yeah. And they are revising it again because obviously they picked the most common, or what they thought were the most common presentations. But right now we're starting to realize that it's not only that, there's just so much more to it. And this is actively being revised right now. But the thing on this with the Ehlers-Danlos, the hypermobile Ehlers-Danlos syndrome, is that we just need to remember that this is a systemic connective tissue, and it is a bit different than being in the hypermobility spectrum disorder, which is, I think, where there's a little confusion.
We have to differentiate that. I think even before going there, Marcia, where is it, like Ehlers-Danlos is a connective tissue disorder, or is it more than a connective tissue disorder? Like the big umbrella of it, because we know that it affects the heart. We know that some of them affect digestion. Some of them affect the nervous system. Like what is the thing that they have in common? Why are we calling it Ehlers-Danlos syndrome?
So the thing that they have in common is a defect to the collagen fiber and the extracellular matrix where the collagen lives, let's put it in layman's terms, right? So that is what they have in common, or we have in common, right? I have Ehlers-Danlos syndrome hypermobile type. So it means that we're going to be bendy. And that's kind of the biggest probably issue that we face, because everyone thinks it's just the joints, right? We're talking collagen, we're talking connective tissue, it's just the joints. But collagen exists in the entire body.
Yeah.
So it will affect the cardiovascular system, the neurological system, the gastrointestinal system. I mean, it will affect the entire body differently for each person. So a presentation of one patient might not be the same presentation of another. While one can have more of the shoulder hypermobility or dislocation, another patient might have more of the hips. Someone might have craniocervical instability. Someone might be a little more stable up there, have some hypermobility, but it's not as significant. So each patient is completely different from the other.
And just for clarification too, we talk a lot about connective tissue in our profession. We talk a lot about myofascial tissues. We talk about fascia as a connective tissue. Collagen is part of that connective tissue. And there's various types of collagen. So a lot of times when we talk about an injury, you will see a type 3 collagen that's part of the early healing of those injuries, and then it converts into type 1, which is longer lasting and the more permanent. What we're talking about is this is a dysfunction of this collagen in its normal function. So it's not doing its normal behavior. And that's why we're
Yes.
seeing dysfunctions in a lot of these different systems. And I learned a lot of this from you, and that's why I'm just sort of paraphrasing it, but thinking of, how can somebody who has been diagnosed with it, or maybe their parents had a classical Ehlers-Danlos syndrome, and maybe they have a hypermobility, like how do we start differentiating this? What doctor would somebody go to even be able to be tested for Ehlers-Danlos syndrome in any of the 13 categories?
Let's take it in parts, right? So you mentioned first genetic versus acquired, right? So genetic, obviously, the primary would be that you acquired it from your mother or from your father. One of them would have the marker. We believe that it is a dominant characteristic right now, instead being you having to have a father
Recessive.
and a mother. Yes, that means a recessive. You need a mother and a father. You only might need just one parent to have it. So that's transferred genetically from one parent to you. Then there is the environmental, or there's something that might have happened in the development actually, where your genes or your cells are breaking down and dividing, and some defect happened there. And then the parent doesn't present the characteristic, but you were born and you present with it. And then there is someone that has had the genetic marker. It means that defective gene that is expressing, that is producing a good protein. For some reason, you're not presenting any symptoms. And then you got sick. Then you had a surgery, then you got into an accident, then you have a traumatic event in your life, whatever that is. And all of a sudden, it's a cascade of symptoms that you never experienced in your life. And you just don't understand. Nobody understands. You were not sick before. So something changed. It's epigenetic. Something changed and caused that to generate all those symptoms.
We've seen things like different types of viruses or even parasites or environmental triggers for many autoimmune diseases as well, right?
Yes.
So we sort of see this, somebody has an underlying rheumatoid arthritis genetic predisposition, they smoke for 20 years, and then all of a sudden they have a very high risk of, depending on how long they smoked, that'll trigger that genetic anomaly. And then they manifest an autoimmune disease that starts to munch on their cartilage.
Exactly.
I find this very interesting in looking at, and again, we don't want people to go around being paranoid of what happens. Like life happens,
Exactly.
We get sick. Some of us have the genetic factor, some of us don't. It is called a syndrome for a reason, and that's because there's still so much unknown about it. It's not like we just go, do a blood test and find out that we have AIDS or we have some kind of marker of a disease. So let's take it a little bit further now and jump into the area that we really want to talk about, which is the hypermobility Ehlers-Danlos and the spectrum of hypermobility in and of itself that's not Ehlers-Danlos. Because I think there's a lot of physical therapists that throw EDS out right away, Ehlers-Danlos right away, if they see somebody that has some hypermobility, and the patient then goes on to the internet and looks up Ehlers-Danlos and they freak out when really they might just be on the hypermobility spectrum of normal or a little outside of normal.
Exactly. So the main difference is exactly the word syndrome, right? That means that more than one system is involved. While the hypermobility spectrum disorder, you might even have some compromise of certain systems, but it will be very light. Essentially, you don't meet the criteria that today we have established. So remember that this criteria is being revised, this might change, but then that person does not meet the criteria. So you might have someone at the hypermobility spectrum disorder just because they haven't met what we call the criteria currently, but doesn't mean that they have less pain to their joints, doesn't mean that they are less comfortable or less uncomfortable with their symptoms. It just means that they didn't meet or check all the boxes they needed to. Let's imagine that if we have a graph, and here we have the complexities of from mild symptoms all the way to severe. And here we have the types of connective tissue disorders involving hypermobility spectrum disorder to the most complex Ehlers-Danlos type. So if you think that graph being this way, you're going to imagine that if on the hypermobility spectrum disorder being your first one, your symptoms are more like towards the mild. So you don't have as much complexities to your digestive system or to your neurological system. You might have a couple things here and there, and you're okay overall. And then as you start approaching more towards the Ehlers-Danlos syndrome, you have more of the systems being compromised. You're presenting with, let's say, mast cell activation syndrome or POTS, postural orthostatic tachycardia syndrome, which is your autonomic nervous system now being affected, or you're starting to present with some abdominal compression syndromes or digestion issues. Digesting is lower, digestion imbalances and things like that. So that there are several things that can happen. And as you progress, as your symptoms get more severe, so more complex become as well the types of Ehlers-Danlos syndrome.
And it might be worth saying that, there's names for all of these things, medically speaking.
Yes.
But what you said, and we want to make clear, is like it's the different physiological systems in the human body as it becomes more complex that are affected. So we talk about the digestive tract, we talk about the cardiopulmonary tract, we talk about the nervous system, the reproductive system. So as you look at more and more of the systems, the integumentary system, which is your skin, the musculoskeletal system is what we look at when we talk about the hypermobility part of it. And we're going to get into that much deeper as to how do we remove the fear, what should we be doing, what are the indications for people that have the hypermobility. But I think it's important to understand, like, for example, with me, I definitely had all that hypermobility very young and through my life. Like, it was easy for me to be a dancer. It was easy for me to show off and do the splits. It was easy for me to do little contortion acts and things like that. But I never had skin that was super stretchy or anything like that. I never could get my thumb down to my forearm. I wasn't hyperextended in my elbow. So if you made me go through the test, I wouldn't be positive. I wouldn't have a real high score on the test. But I mean, I certainly could put my elbows on the ground, for example. Like I had so much flexibility in that direction. I could do the splits and I could dislocate my shoulders, sublux them to bring them around over my head, those kind of things. And then the type of sport that I did was quite aggressive and probably was the wrong thing to do as somebody that was in the hypermobility spectrum, because I dislocated shoulders, I dislocated hips, I dislocated a talus, I had a number of fractures and eventually broke my neck. And then I had, so it's like just so many things, but they were all traumatic. But I always wonder, Marcia, is like, well, if I wasn't on the hypermobility spectrum, would I have had as severe of results from those traumas as I did being on the hypermobility spectrum? And of course, I don't know the answer to that. I sometimes I wish I would have been more interested in something that was not quite as, like falling down from 15, 16 feet all the time.
That definitely didn't help.
But I loved it. I loved it. It was everything.
No, but I think that's the biggest thing. For example, we're talking about you, and then we get all the symptoms in this presentation from you, and then we compare it to mine. Not that we should be comparing patients or individuals, but just for the.
Well, I think this is good because
to see the difference. Let's say
we both felt that I was not EDS, but I was definitely hypermobile.
Hypermobile, but you see the amount of dislocations and tissue trauma and everything that you went through. Even thought you were you are more so in a hypermobility spectrum disorder range, while I am a hypermobile Ehlers-Danlos patient, and I haven't dislocated my shoulders. I can reach, I can type on the table behind me without turning around, but I don't dislocate my shoulders. But my issues were more so in healing when I had my surgeries, and then my digestion, the anesthesia trigger issues with my digestion, trigger issues with my ability to heal. I ended up on a wheelchair and I couldn't digest anything. I couldn't stand up because of postural orthostatic tachycardia syndrome, which I didn't know I had. And now I recall passing out as a child, well, not almost passing out as a child, falling like, I feel like I'm going to pass out, and fell. And I'm like, I wouldn't go completely unconscious, but I'm like, what is this? And now we're both in a little more advanced age, and we are both like, paying a little bit for all the traumas that we cause to our bodies, but overall we are doing well in different categories, right?
Yeah. That's interesting. Well, I mean, we certainly, the thing that I'm sort of realizing now, and this is another, I don't know if it's a myth, but we look at it, it's like now in my 60s, I find that I'm losing that mobility that I had, right? It's more like I struggle more with some of the arthritic changes and the some of the restrictive capsule changes and trigger fingers. And, I wake up in the morning and I can't straighten my index finger on the left hand. And, so there's other connective tissue. And I guess this is where we come back to is the collagen response, the healing response that is not in its best state. Like it's like you think like you maybe strain your finger picking something up. You shouldn't end up with nodules on your tendons and the pulleys and end up with trigger fingers. It's like that's not a normal thing.
Is that change in the connective tissue architecture?
Yeah.
It's as you are exercising and traumatizing the tissue in wearing your joints a little more than a person that does not have a connective tissue disorder.
Yeah.
We have that early onset of arthritis as well. So I like to see this as a phase where, as we're getting into puberty, the pain phase, right? They're very hypermobile first and they don't have really pain or they have a little discomfort. Then they start going to puberty, getting to the teens ages, and then they are experiencing a lot more pain and a lot of hypermobility. And then as we start getting older, we have a lot of pain, but we start declining in mobility because we start becoming a little more arthritic. Our joints it's like having a door with a loose hinge. It start wearing out the floor or the frame of the door. That's kind of what happens to us. And as we become more stable because of that arthritis, the pain starts easing up a little bit. And in some cases, I have patients that told me that all of a sudden my pain was so much better as I aged. They still have other symptoms, but the pain itself had improved significantly.
I could see that. Question for you. Are there any tests out there now that in pathology labs that could actually look at the collagen with somebody with EDS and be able to identify that there is a change in the collagen makeup or the genetics?
There is a study. They looked at different fibers for the different syndromes within the Ehlers-Danlos types, right? And you can see that the fiber arrangement, it's not the same as we consider a normal tissue or a reference tissue from a person that didn't have any symptoms of connective tissue disorder. So when they compared each syndrome under Ehlers-Danlos, they could see that the collagen
There's a pattern.
Orientation and arrangement was different for each one of them from a person that is actually considered not in the hypermobile spectrum.
Interesting.
It was very interesting, but there's no genetic testing, as we know, for hypermobile type.
Now, when we talk about hypermobility in general, right, let's define hypermobility syndrome without the EDS. Like what's the big differentiator between hypermobile Ehlers-Danlos versus more like what I feel like I'm self-diagnosing, but just hypermobility spectrum?
Yeah, so the hypermobility spectrum disorder, you are double jointed. Not necessarily everyone, for example, that's bendy should be called hypermobile. There is acquired hypermobility as well.
Yeah.
Someone can develop that level of flexibility by working in like Cirque du Soleil or anything, gymnastics. Exactly. You develop that length. But if you are naturally bendy and you don't present with any other systemic symptoms or very mild discomfort here and there, that is hypermobility spectrum disorder. You're very flexible, you're very bendy, but you have no chronic pain, you have no herniations, you have no cardiac problems, you have no neurological problems, or if you do, it will be minimal in terms of digestion or maybe a little increased heart rate. But in general, because they are able to function a lot better.
Mm-hmm. I think that's such an important differentiation for us to make and I think what I'm hearing is somebody like me never had pain.
So you
I
could
never had
function
pain.
better. So you could
I could
exercise.
do everything. I was strong. I was flexible. It came very easy to me.
Yes.
You know, I mean, they called me Mrs. Anderson on the football field because I could do the splits, or Sharky because they said like I didn't have bones. I was just cartilage. So I had these nicknames, which I just thought they were just jealous of me. I was very proud of being flexible.
And they were. I'm sure they all were very jealous.
And yet, for me now, older in life, now my pain is now mainly because of degeneration related to injuries that happen probably from doing high contact, high force sports that, you know, with a hypermobile body. So that really is a big differentiator. And I think when you and I talked about this, it was very clear that I was not very unlikely that I have hypermobile EDS, but more just that I was in that hypermobile area. And I think that, you know, if I would have even known this, not that I would have, and not that most kids would know this. I mean, if you're in hypermobile, you often get attracted to the dance world, to the aerobics, gymnastics, and like you said, and now even more, there's a lot of people doing contortion and those kind of things, and the yoga world that we get attracted to, Pilates world.
And that's kind of what can cause more damage, right? And we have to be very careful with it. Not because you can, it means you should.
Yes. And I think this is where, again, something that you taught me was this idea going into how we approach somebody's care when they're in this hypermobile and even more aggressive if they're EDS. But it's like, it's education. How do we teach people like ourselves when they're younger and they're manifesting these to work within a stable zone of movement that is not always going to an end of range. It's not always taking their tissues to a point where they could potentially, you know, do more harm to their tissues in their body.
Yeah. So I think we need to think, because we said it's a tissue architecture problem, right? And so that will certainly lead to a structural and a biomechanical difference that can affect multiple systems in the body. So being mindful of that is essentially saying, because you can go far on your yoga, because you can turn and twist 10 times, because you are very good at gymnastics or cheerleading, you gotta be careful though, because eventually that can lead to an injury that can take you out of the sport or the modality you enjoy. So being mindful of parents, being mindful because your child is very bendy, very, does well in dance, ballet, you gotta be mindful of those injuries.
You had shared something with me of saying that in the diagnostics of these, that it is more of a map, not just, a sentence.
Yes.
And so nobody really is the same in these diagnoses. There's no two people the same in their manifestation. I think that's another really important point for our audience to listen to and to know that, you might have bits and pieces. You had mentioned that somebody has more shoulder issues and somebody has maybe a little bit of the cardiovascular with the POTS, or somebody has a little bit of the, digestive kind of thing, like you said, that was triggered. But everybody can be different. Who do we go to look and create the map that would potentially manifest that we do have something like EDS or hypermobile EDS, or we don't?
So everyone thinks it's the rheumatologist, right? But the rheumatologist is usually well-versed in autoimmune disorders, right? Ehlers-Danlos syndrome is
not
genetic, is not autoimmune. It is under the 2017 criteria. Under the criteria number 3, you need to rule out any autoimmune disorders that can be associated, or some patients do present with autoimmune disorders and hypermobile Ehlers-Danlos syndrome, but that's a little more complex.
They put fibromyalgia into rheumatology, which I don't understand.
Yeah,
that doesn't make any sense. But we don't have to go there. We'll come back another day for fibromyalgia.
Yeah, we'll patch on that one the other day.
Also a syndrome.
It's also, yes. And then patients with hypermobile Ehlers-Danlos do have fibromyalgia too.
Yes.
So
yeah,
not always, but may have it. All right, let's think it this way. First, remember, hypermobile Ehlers-Danlos syndrome, we don't know what gene is causing it, right? So you get the 2017 criteria. That's the best we have right now. And that's where I say we have to get creative with that, because that is definitely not covering the reality of a AGDS patient. So you get that criteria, you go through criteria 1, which is the Baton score. So you need to score 5 out of 9. Yes, a 5 out of 9.
Let's tell people what that is, because I'm
so
looking
it's
at
the
a picture
thumbs,
of it
right?
here.
You get the thumb, and if you're able to bend your thumb and touch the forearm, that's a 1. I can't do anymore because I have a dislocated thumb. Look at that, how fun. My thumb decided to go out and not go back anymore. My line used to be my joints go out more than I do. Now my thumb went out for cigarettes, never came back. As thumbs touching the forearm, and I could do it so much with ease as a young child. Now I can't because I'm arthritic. So see, pinky, the pinky has to go to 90 degrees or more. So right there.
That one I have.
Yeah, that one I have too. Used to be more. I used to touch it to the back of the back of my hand. I can't do that anymore.
Easy for me.
Yeah. The other side too. So you get 1 point for each one, right? So it's 2 thumbs, 2 pinkies.
I have 2 points.
You got
right
2
now.
points. I got
no
2
thumbs,
points
but
right
I got
now.
2 pinkies.
Yeah. 2 pinkies. We got the pinky promise together. Now then I hyperextended elbow. I don't know if you can see, but mine does hyperextend.
You do. I don't.
Yes. So I got both. I got hyperextended bilateral elbows. So that's 4 for me.
2 for me still.
2 for you still. And then we have the knees, right? Which means you stand up and you press your knees back and you don't lean forward to look at it because that deceives the purpose. Someone else is going to look at it and tell you if your knee is in line or if your knee has done this, arch back.
The hyperextension of it, yeah.
Yes.
Record bottom.
I get that one too. And then on both sides. And then finally being able to touch your hands, palms flat on the floor with the knees extended with ease. So if you touch your palms completely flat on the floor, your knees are extended.
How many points do I get for the touching the palms to the ground?
It's 1 point.
So I'm 3 points out of 9?
You're 3 out of 9, but hang on, it gets better.
Okay.
So you see, you're 3 right now as we are. You were 3, I am a 7. Okay. Now there is the historical part of it. When we ask you, were you ever able to get your thumbs to touch your forearms?
Yes.
Me too. I was a 9. So here you go. Looking historically, we are already considering you now in a 5. You are not a 5, you were a 5. And then we ask, were you ever bendy enough where people said you could do party tricks? Were you ever able to do splits?
Yes.
So then there you are.
Chinese and American splits both.
Wow, that's really good. You bit me to the chase on that one. I couldn't get the Chinese one, just the standard split. I couldn't understand why the other girls struggle so much on the ground to get a split. And I was just down there, like looking at one side, looking at the other, and they were like struggling.
Yeah, I could lay flat on my belly with my legs out all the way. Like, it was ridiculous.
I know. I was just there, like, picking my toenails on each side as they were struggling and trying to stretch. So that is the Baton score. Now we go to the criterion 2. The criterion 2 under the 2017 criteria. Then we are looking at skin quality. So everyone thinks the skin needs to be super stretchy. That's a myth. Let's myth bust right now.
Yeah, good.
It's mild skin extensibility. If you actually can pull your skin and cover your face with it, you got a different type of Ehlers-Danlos. All right? And there are, if you Google skin extensibility
I've
or
seen
Ehlers-Danlos,
some of those pictures. They're crazy.
some crazy ones. Yeah, but those are different types. So like if you got looks like your t-shirt was a little bigger than the natural, you get it on the arms too. You can get on the side of the neck and you can stretch it out, and it's mild. Okay. Now, a person that does not have EDS, when you try to get them, it's just tight. You hardly get a pinch out of it, but you're not super stretchy that you're pulling it off completely.
So that's a different variation of the EDS when you see that.
Yes.
Really.
Yes. very stretchy,
Yeah.
or that person that has that the skin looks like the little Shar-Pei dog. It's all,
Right.
and they are like young though. We're not talking about a person at their 80s, 90s. We're talking about someone in their 20s. That's
Yeah.
a different type as
Yeah.
well.
I've seen that.
So yeah, so let's not get confused with those. Then we are looking at how the skin quality is very velvety, is very delicate skin, right? So that's another point. And then the skin transparency, like you can see the veins. Now let's remember that there is vascular type of Ehlers-Danlos syndrome, but the skin being translucent is one of the characteristics. Now, obviously, we have African Americans with AGDS, and they might say, well, I can see my veins. So there are things we need to
Variations.
take into consideration, right? Or
Yeah.
someone took a lot of sun, spent the day at the pool, you are not going to see, you might not see, right? The next thing will be stretch marks that were unrelated to gaining or losing weight. They usually come up when you're growing up, mostly on the back.
I have those.
Yeah, there you go. See, I don't have on my back, but like I was as skinny as a toothpick. You wouldn't believe. I was olive oil growing up. And I had those stretch marks on the sides of my hips and on my glutes. And I'm like, where did that come from? I'm not even overweight
Right.
because I didn't understand.
Yeah.
So
And I didn't know
is
that I didn't know that I had that, but when I saw my functional medicine doctor a year and a half ago, he brought that to my attention that there was like some striations in the lower flank of the back.
Yeah. So see,
And I've never been obese, so it's like, the amount of
where
weight
did
I've
they
had.
come from, right?
Yeah, exactly.
Now, one good thing to look is a scar from your surgeries. Like my scars, they are not a thin line, a pretty thin line that was a stitch. My scars, they are all separate, and there is like a thin film, a thinner film in between. Some patients will create this elevated scar. Some are going to create like almost like a fascia
Hollowing.
defect.
Yeah.
Yeah, so if you go into my scars and you press in, you can feel the fascia defect underneath.
Yeah, I don't have a problem with the scars, but I've certainly felt that with many patients
Yeah.
that,
And
there's
not
some that
everyone
have
has.
yeah.
Some patients will have elevated, discolored, different presentations.
And
They're
that's
still
different than
hypermobile.
keloid, which is a completely
Different than
different thing.
keloid. A person that doesn't have Ehlers-Danlos or hypermobile spectrum disorder still can have a keloid.
Yeah, yeah.
That's just a healing, a different thing under dermatology now, right?
Mm-hmm.
Then we're going to also be looking at other things like we see, for example, how long your fingers are. They're still looking at it, which is more like a Marfan syndrome type.
Yeah.
Yes. So they look if you can wrap around your wrist and overlap your thumb of your pinky nail. I used to be better at it, but with my arthritis, I can't do anymore, but I still get it. I get my thumb to overlap my pinky nail on both sides. And
No
then
way.
we have, no way. Now you can get your thumb, stick it right in there, and close your hand. Then is it showing out there? No. Okay. You see? But not everyone has this.
But that's interesting. And again, it's like you're saying, this is the mapping. Like we're mapping and we're
Yes.
looking at a collection of things. You've ruled out autoimmune diseases. We've ruled out a couple other things.
Oh, we didn't even get there to rule out those yet. That's criterion
We're just
3.
screening. We're just screening
We're
right
screening. Right now, we're looking at what happens to the body, right?
now. Okay.
So after that, we also gonna look at how tall they are and how big is the wingspan. So now we can look at Michael Phelps, the 6'7" wingspan with the 6'4", I think he is.
Yeah.
So a person that has 1.05 more wingspan than they are tall.
Interesting. So I'm almost
Right.
exactly like my wingspan is 6'1 3/4, and I'm 6'1
I'm
3/4.
exact by a half inch shorter on my arms.
Yeah.
I mean, I don't know. I've been shrinking since
I'm
I've been
shorter
getting
now
older,
since I
so
had
don't
the
know.
cervical fusion too. Yeah.
Okay, yeah. So you see, there are other things as aging, surgeries, things change.
I told him to put a big piece of bone in between the vertebra, but he said
To
it didn't
keep
fit.
it,
He said it didn't
didn't
fit.
fit.
It didn't fit.
Maybe he didn't try. He's just like, I'm going to shorten him up. The other thing is also, remember, this is a Marfanoid look, right? Which they think and they consider still that we should have, or we have a Marfanoid look. But I have patients coming through my doors that they're far from being Marfanoid look.
Yeah.
and they still have AGDS. So that, I think I see that changing as well.
Interesting.
And then there will be a history of hernias, abdominal hernias, if they have or not, tooth crowding, and narrow palate and very high palate. And that's a marker that I see a lot. That one I see a lot.
I wasn't familiar with that. I hadn't heard of that one. Yeah.
And we kind of have the same features. Sometimes there are patients that walk in and we even joke like, oh my God, we look so much alike, facial features, right?
Well, you see that with other genetic diagnoses, right? That,
yes.
I mean, much more severe ones, obviously. But when you look at trisomy and you look at Down syndrome, I mean, there's such a common structure of the face and the jawline and the cranium.
Yeah, so we have like a narrow palate and the teeth have no space to go, so they crowd, and then the palate is really high.
Right.
That's another thing. But there is a specific syndromes that have dental problems, but yet AGDS, there are patients that have severe periodontal issues.
I saw that on one of the lists that it was like just the gum line and stuff not covering the teeth. Like there's a lot of other things that are involved in that. The dental one of the groups.
Yeah, and I have had dental bone implants on my gums starting at age 13.
Really?
Yes.
Wow.
It was incredible.
So I hope as people are listening to this too, it's like you're sort of going through, and what we hope to do is that people sort of look and they go, I don't have that, I don't have that, I don't have that. I have a little bit of that, I have a little bit of that, but I don't have this. We can sort of remove some of the fear of thinking that you have this something that is much worse collectively.
Yes.
Yeah.
And you see, it's not on the criteria periodontal issue, but I had it.
Yeah. But I saw it in there. I saw it in the new criteria list that there is periodontal classification of Ehlers-Danlos.
Yes. Yeah. Exactly. There are periodontal classifications, correct. They're looking more into it now. But on the 2017 criteria, it's not there. And then we look at heart problems, aortic problems, aortic root dilation, mitral valve prolapse, or valve prolapses in general. They look at it as well. And then, let me see, I don't think I missed any. Oh, the piezogenic papulas, the cute bubbles. If you take your socks off and you stand up and you have someone look at your heels, you're going to have, if there are little bubbles, little balls that show up on your heels around, those are called piezogenic papulas. I nicknamed them the hernias of the heels.
The heel.
It's the same concept of when you have a hernia, an abdominal hernia, something pops through the connective tissue, right?
Yeah.
From an injury to the wall. Well, that is your connective tissue and your fat pad as you stand and we are heavy. Well, let's think about it.
It eventually over the collagen time, and pushes through.
It pushes through. So when you sit, it disappears. When you stand, it reappears. So those is a very common marker that I see. And then now we jump into having the next question will be, do you have a family member that has
these kind of
similar symptoms? And it's a yes or no, a direct family member, immediate family member. And then the next thing will be, do you experience pain to 2 or more limbs every day for at least 3 months? And this is usually a yes for like 99% of the patients across my doors. And then it has to be 2 or more limbs daily and recurring for at least 3 months. And then generalized chronic pain for 3 months or longer as well. And then finally, we go into the criterion 3, which is going to be 3 items only. That's quick. Criterion 1, eliminating any other genetic tissue disorder that could cause abnormal skin fragility, which it's quite quick. Number 2, eliminating every autoimmune disorder or acquired connective tissue disorder, which is done by the rheumatologist. That was your question. Right? And then the third one, eliminating any other connective tissue disorder by genetics, that's genetic connective tissue disorder that could present with similar hypermobility feature. And that's just by the geneticist. But not everyone is running genetics. Genetic testing is expensive. Not every insurance covers. And at this moment right now is not going to change unless the geneticist believes that you might have another syndrome, unless we need to look at metabolic syndromes, unless we need to find out if you're MTHFR gene positive, which is a methylation gene that affects a lot of reactions or things in your body.
And there's a lot of information coming out about the methylation right now. So
yes,
yeah,
there is.
let's just recap real quick. So basically, there's the Baton hypermobility test that almost everybody that sort of learns the first level of hypermobility and Ehlers-Danlos has that test, which looks at the 9 things that we looked at. The new classification, which is called what?
2017 criteria for the diagnosis of hypermobile Ehlers-Danlos syndrome.
Yeah. What I want the audience to understand is that this is a classification process trying to help us understand what it's not, and then how do we treat something that falls into a syndrome that affects multiple parts of the body and the well-being and function. So that's where I want to...
It's a map. It's a map to give us an idea of where to look next. That's about it.
So I want to move into the next part of this, and that is dealing with fear avoidance. So let's talk about people that actually have the diagnosis. They've been diagnosed with hypermobile Ehlers-Danlos syndrome. And how do we educate them, or how do we help them to avoid what we call a centralized pain aspect of it that often accompanies these type of syndromes, where the fear of it can lower the pain threshold. The repeated stimulus of painful activities can also increase that hard wiring in the nervous system. How can we use sort of like Adrian Lowe's approach of neuro and pain education in this population to at least optimize the ability to minimize pain?
So I think the first thing we need to talk about here is that the diagnosis is not a life sentence, right? This is just a diagnosis, is putting a name to what you have so we know what to do with it.
Right.
Correct? So that's the first thing. We need to also to pay attention to what's going in the brain when someone hears a diagnosis like this. So the main thing it's going to happen first. You know nothing. You know you're in pain. You know you're maybe dislocating, subluxing, having issues. All of a sudden you hear you have hypermobile Ehlers-Danlos syndrome. The first thing you're going to do is your amygdala, which is your primitive part of your brain.
Fight
or flight. Exactly. Your amygdala is going to come up and say, whoa. It's your automatic threat detector, right? It's quickly kick in and it's going to go in overdrive, and it's going to stay overactive after repeated injury or repeated pain. So now you got a diagnosis, you already been going through a lot of pain and injury, searching for doctors, trying to find a diagnosis. Now you hear something that sounds terrible because it's a very complicated name.
Yeah.
Right?
And even if you get this diagnosis, I mean, just Dr. Google in itself is scary.
Yeah. So that's just neurobiology, right? The amygdala is going to kick in, which is the primitive part of your brain, and it's there to keep you safe, right? So, but if fear stays switched on, it will keep you from doing the very things that will help you to get better. Right? So if we think, so the amygdala is your automatic threat detector. If it stays on, you're going to be afraid of injury and pain. Right. Then your hippocampus, which is another part of your brain, will pair that diagnosis with the past danger experiences in movement. Because you remember, you didn't go to the doctor when you first felt the pain. You went there after it. That might be your 5th doctor.
Yeah.
Right?
Which even makes it worse. I mean, this is what I fight all the time, right? So my specialty is chronic pain, and is looking at what is being experienced that is a centralized pain mechanism like you're talking about, where there's a trigger and it goes in and hits the amygdala, hits the thalamus, asks the parietal lobe, hey, do I need to worry about that? Hell yeah, you got to worry about that. You have Ehlers-Danlos syndrome, And so then it goes to the frontal lobe, and the frontal lobe expresses pain. We have to be conscious to have pain. And it's just this vicious cycle, right? And it's like...
Yeah, but then your prefrontal cortex, which is your logical, it becomes offline. because the amygdala is dominant now. So
That's
your
right.
prefrontal
You're in
cortex,
sympathetic mode. Yeah, yeah.
exactly, because now you have been to 10 doctors already. They keep telling you have nothing, you're too young, you look too pretty, you look too good, just hit the gym, you need a psychiatrist. And that amygdala is just like lighting up like crazy. And then your hippocampus is like, oh yeah, remember all that stuff? Let's keep the amygdala going. And then your logical brain, which is your prefrontal cortex, is just like
Turned off.
turned off,
Yeah.
right?
Like, how long is it typical when you're providing this education, Marcia, to somebody that finally got a diagnosis, 5-10 years later, they finally got a diagnosis, they're in this acute state. What kind of response do you see once you've been able to educate them?
Each person has their own journey. It's very, very difficult to get this message across sometimes because we are talking about the brain. And when we talk about the brain, because a lot of these patients have been told it's in their head, they become very defensive when you start talking about the brain.
It's not a
But
psychological disorder.
I mean, it's just said it's not, but it being told they are literally in need for a psychiatrist. Yes, I would, my line would be, yes, I need a psychiatrist. You guys are bullying me so many times that now at this
Yes,
point, I really need
that's
to
right.
get some grounding
Well,
and find myself
it's
again.
definitely neurological. I think that's what
Yes,
the first thing we understand. It's also going to be hormonal. It's also going to be,
yes.
when these things fire up, it affects everything. And that's the last thing you need
Is someone telling you that's in your head?
when you have a syndrome like this. It's the last thing you
Exactly.
need.
Because fear, you see, fear creates avoidance, which leads to deconditioning, which leads to instability, which will confirm the fear. So you just got stuck on that amygdala and that loop, and you can get out.
So let's talk about reversing that loop. I mean, this is the climax of our show today.
Yes.
Is all right. So we have this person, they're in a heightened state of fear. The amygdala is running wild. They're in sympathetic mode. Their symptoms have worsened since they got the diagnosis.
Mm-hmm.
They're looking for help. They get referred to you, and they come in. You provide them some education. What is it that they must have to be able to start shifting this cycle, this vicious cycle that they get caught in? That, like you said, it's a spiral down. You have pain, you have fear, you have inactivity, you have deconditioning, you have increased instability, you have more pain, you have more fear, and it just, it's a horrible spiral down. I remember a young woman I had that completely dropped out of college, and she was trying to lay on the floor in the lecture hall to try to listen to the lecture, and she just couldn't do it. She finally had to drop out. And her father was a rheumatologist. And, it's just sort of an ironic kind of thing, but she was truly manifesting and finally gotten the diagnosis. But it was actually her father did not want her to have the EDS diagnosis.
The father was in more denial than the patient.
Absolutely. But when
It
she
is
finally got the diagnosis and we started working with it, and that's when she was sent to me, we start this process. And I'm curious if I was barking up the right tree or not. You've done this many times, but how did you decrease the psychoneural aspect of the pattern, right? The fear and the belief that you can't get better and the belief that, you're on this lifelong spiral down to where all of a sudden they're realizing that there is something they can do and that they can get better. They can have a much better quality of life.
I think the first thing is acknowledging them, right? People need to be acknowledged. They need to be validated for the symptoms they are experiencing. And I think the first thing that I try to do is to tell them that it is okay. It is okay to be in pain where you are at right now. You are in the right place. Let's work together. This is a holistic approach. You're not going to treat, it's not one professional that treats. We need to team up different specialties because we do need a person that will help them with their fears, with their, psychological, emotional. At that point, I've been there. If we don't have
Do you
that
feel
support,
like you have a good, complete team for your patients? Everything from the psychologist, the
I never think I
nutritionist.
have a complete team. I always think I can get better.
But I mean, do you have like a black book of nutritionists and psychologists and geneticists and
I do, but it depends. That's the thing. It depends on what
the
presentation
individual?
that patient has. Because if we are talking about a patient that has gastroparesis, but also has celiac disease, and then also has absorption issues and MTHFR, that nutritionist or dietitian might not be the best.
That's
They have
true.
to have another one. So now they have mast cell activation syndrome. If that dietitian or nutritionist does not understand mast cell activation syndrome, I have to resource to, okay, let's bring in an allergy immunologist, which I do have different specialties. But then we hit into issues like, well, they don't take my insurance, or that test was too expensive. I am overwhelmed with tests and physician's appointments. I just can't do all this. It becomes loud in the head when you have so much going on. What I try to do is let's see the priority of the things we need to address. And some patients, I say, listen, we're just going to start here. I don't need to send you anywhere else. Let's just get you for 3 months, 2 months. Let's tame down the lion and then see what is left. Because you got to remember that your brain is going to be lighting up like a Christmas tree at that point. Your fear, your avoidance, your fear of movement, fear of even eating certain foods, you need to calm the system, get them out of fight or flight. So we're going to work with breath work. We're going to work with some tactile stimulation and kind of calm them down. And then we see, okay, what is left that now truly needs to be addressed because it is a system issue, right?
Yeah.
So give them like a little more idea of, for example, pain perception and central sensitization issue. The pain can persist without tissue damage due to the central amplification of pain, right? So did we get them better mechanically, but they are still in pain? Right? Is that volume knob in your brain that regulates pain and in your anterior cingulate cortex
turn it down?
And insula? Can we dial that down, or now we need help from someone outside?
I mean, this is where, we can create successful movement experiences that do not exacerbate their pain.
Yes.
And do not leave them with residual pain, right? Does that change the dialogue? If they have enough of these positive experiences, is that one of your best tools to shift the dialogue in their head that is dialing up the pain, right?
Yes.
It's like there's got to be a point where, and I know it's different for every person. Trust me, the same thing with any kind of chronic pain. If you've had it for 20 years and your whole life revolves around it, having 6 weeks of really positive Pilates or gyrotonic or yoga experiences are not going to be enough typically to shift that neural network. But, maybe if it's a year, we have a better chance of doing it quicker. We can get on top of it faster.
And these patients are not a traditional 3 times a week for a month or 2 months of PT. They're going to get them better. These are patients that are going to take 10 months, 12 months, a year, because ligament laxity will decrease passive joint position feedback. So you now don't know where you are in space. It's like you have a very noisy proprioception. That puts you on fight or flight, right?
Yeah.
Now you're already on your amygdala is in hyperdrive and you don't know where you're in space. Then you have that uncertainty will shift your brain into a protective mode. So now, again, the amygdala is lighting up. And then if you actually start giving them a rich but dosed proprioceptive input, like you start giving them a little more closed chain where they're more stable, you give them some tactile cueing, some calming touch during the movement. Some patients don't do well with compression garments. Some do really well, or weighted blankets.
I was just going to ask you, if you're using the weighted blanket to be able to get that sensory stimulus. Interesting.
Some people just get here, they're almost vibrating out of their skin.
Yeah.
So that will actually improve the cerebellar mapping and will calm that threat response. And that's when you start calming them down and you start regulating a little more of the system, and you start being able to finally do a neural retraining, right? Where you're gonna
Neuromuscular re-education. It's time to...
neuromuscular re-ed and
Yeah.
neuroplasticity.
Yeah.
Safe repetition will strengthen those motor cortex maps where you will be able to give them a more, this movement is really safe. It's small, it's basic, but it's safe. It's okay to move.
Let's talk about that safe movement. I mean, this is something that I've learned years ago in my PhD. We were looking at this very topic with chronic low back pain, was that if I could create, and this was one of the more powerful sort of justifications of what we were doing with Pilates, particularly the equipment, is that we could create movement experiences that had a modified load, a modified orientation to gravity with a focus on staying within a dynamic alignment of actual structure. And that if we could create that successful movement without increasing the pain, first of all, but then creating movement experiences that exceeded their expectation. So it's like all of a sudden now we're doing something that they thought, 2 months ago, that would have killed me. And I just did it, and it didn't hurt, and I was fine for the 3 days after. I didn't have any aftermath like I've had when I've done gym training or exercise training in the past. What do you use, Marcia, when you look at this graded early exercise, early work with the clients? And what I'm looking for now, really is looking at indications of intervention and less contraindication. Because I think everybody sits there and goes like, look, okay, we're not going to work in extreme ranges of motion.
But what is safe, right?
But what's, so how do I find what's indicated? How do I create this safe environment that you're talking about?
Okay. So the first thing I really want to say, and I want everyone to remember, why movement works on the brain. We need to understand that, okay? So first thing is neuroplasticity. Like I said before, safe repetition will strengthen the motor cortex and the maps there are in there for the different movements. The cerebellum, that posterior part of the brain down below, it will, if you improve that proprioceptive input, it will refine coordination and balance, will calm the system. If we actually start having to do predictable movements and that they don't get injured, that they can repeat safely, now that predictable success that they are having will decondition the amygdala.
Yeah.
Right? And then the reward circuits, the dopamine will reinforce movement habits after each small win. Yes, exactly.
Oh, Huberman would be so proud of us talking about dopamine.
I know, right? Look what he did. He created little monsters.
Yes, he did.
So now we're going to talk about what I call it the layered model, which is divided in 3 stages. First stage is the stability. Everyone talks about strengthening patients with EDS. No, you can't strengthen something that is unstable. You can't strengthen something that is hurting. You can't strengthen someone that is on fight or flight with an amygdala lighting up like a Christmas tree. You just can't. So first you need to create stability. You have to teach the joints their home base under a very low tread, meaning isometrics in multi-range parts of the movement, right? Yeah. Not only that neutral isometric that we do here and done, but through the range of motion. So have them work in mid-range control as well. Why? If you go all the way out on that range, you get a hyperextension. If you go all the way in, it's heavy. We still don't have that strength. Let's work the mid-range when it's safe. No dislocations, no compensation.
And I'm glad you're saying this. I mean, I think it was Punjabi, but then, what was this? Mark Comerford. So Punjabi and Comerford and brought it forward as this idea of a neutral zone. Now, they were talking about things about the lumbar spine, and it was sort of a spin-off of work from Paul Hodges and Richardson out of Australia, where it was looking like, how do we re-educate some of these really sort of accessory and small muscles of the spine, right? And it wasn't going to be through doing, back extensions and sit-ups and core training and all those kind of things. That was not going to do it. But what they realized was that if you could restore the dynamic alignment in a small range of motion, and this is the point that everybody's neutral zone is different. You can't say, like my neutral zone of my elbow might be 10 degrees and yours might be 15 degrees.
Exactly.
But we look at where we can have that successful movement and start creating that modified load
for each person
that is going to create. And I love that you said this, like, get the word strength out of your vocabulary right now. Mm-hmm. This level, it's about awareness. It's about, successful movement and that dynamic alignment safely in that space. And we can extrapolate this into, like even when I talk about a flare-up of rheumatoid arthritis, it's like, stay within a very small range of motion. Stay within the dynamic alignment of that area. So,
yes,
very cool.
And work with short lever arms, right? Because if you're reaching out here, the strain on the joints, the end joint is much more. The elbow as well. If you're working with a weight here, keep it in. Keep it small. Right. And work at that smaller range. Once you're becoming more confident, you start going more towards the outer range of that. So now you're
pushing that neutral zone out towards the end.
Exactly. You have to push it out, but you also have to bring it in. You have to work everywhere. But right now is neutral zone time.
Well, I mean, think about it, that the greatest threat to tissue is end of range.
Yes.
That's the greatest threat to tissue, whether it's capsular, whether it's cartilage, whether it's skin, a scar. Yes. I mean, the greatest threat to it is when it's going close to the end of its elasticity. And this is an elasticity problem. It's like too much elasticity. So if we can get more control and proprioception in that more narrow range of motion, they're going to have a sense of safety in that narrow range. I mean, that's where they go.
So essentially what we are doing, we're teaching home base under low threat. That's kind of how I define it. Okay. Then after for each patient, each stage is different too. It depends where they are at when they're coming in. Yeah. It depends on all the other comorbidities as well. If someone that doesn't digest well, someone that's having issues with food, they don't have the building blocks to heal. You can't push them.
Yeah. Right? I like that.
Yeah. And then the second stage is going to be your strength phase, because now the goal is to reinforce stability with a controlled load.
Yeah. That's load when modification.
Exactly. That's now how you start introducing your slow eccentrics, and with your anti-rotation movements, you're still in close, transitioning into pseudo-closed chain, which means now you're moving from a stable surface where your arms, legs, and body are touching to a more unstable surface, but it's still connected to something. You're not with the arms floating in the, with the hands and arms floating in the air. And I also like to bring up on when I talk slow eccentrics, I'm really talking slow. I'm talking about a 4-count eccentric, a 4-count concentric, with a pause at each end of it. So if we're still working towards that completely outer range of motion, if we're still in that mid part of the range, we still can do 4 counts, but very slow and controlled, because we don't want to bypass that muscle, compensate, or use momentum. That is when you're going to get your stage 2 started.
So one of the things that I really appreciate with you sort of breaking down the difference between stability at that stage 1 of just bringing in the proprioception awareness in a narrow range of motion and having that before we ever think of going into strength. You mentioned that the strength idea of doing either an isometric or a small movement of eccentric, concentric, slow movement, Where do we go from there?
So then you're going to go stage 3. So remember too that each phase depends on each patient starting point, right? So some people might be 3 months on each phase. Some people might be a little shorter. Some might be a little longer. The stage 3 is function. So now the goal is to integrate into the real world challenges. So that's when we start adding the functional movement or the functional training to it. So that's where we start mimicking loaded carries or stair climbing or reaching activities or gait if you're training someone to normalize gait. So that's really where we start implementing those strategies and always with a gradual progress. And I think the biggest thing on all 3 phases is remembering to keep the load predictable so you don't fire that amygdala again. If you put them on a flare, and we are inevitably going to flare a little bit here and there, but try to stay as predictable as possible with small progressions so we don't put them into the fight or flight again.
And I like to educate them too that the flare doesn't mean, permanent damage. The flare means that, when you look at tissue adaptation curves, their tissue adapts differently than others. And we need to know. We need to
tap on it.
We need to know where it is that we're going to get that tissue adaptation to happen.
Yes.
And that's why it has to be every individual's unique. We're testing it. But I like to let them know that, if we're getting a day of soreness after an intervention, we're okay with that. If you're
it's a functional soreness. You can do things. You're not in bed all day long.
That's right. But if you're out for 4 or 5 days, we went too far, and you let us know, and we'll come back and we'll readjust and we'll work with it. So it's not the end of the world, but it's also like educating them so they're not thinking that, if they do have that experience, then they're gone. They're marching. Exactly. They don't come back.
Exactly. So these are my neuromusts, right? I call them neuromusts for each stage.
Yeah.
We keep the load predictable. We pair movement with slow breathing. And then we measure the next day response, not just during activity, but next day response.
Yeah, exactly. Now, going to stage 3, this is, one of the areas that I'm also very interested in, which is always what does the client want or believe they should be participating in?
Exactly.
Right, the ICF model. And what activities does that involve? So it's like this is another area that all of our listeners, they have to respect this, that if I'm somebody that thinks I'm going to go climb Mount Everest, is very different than somebody that wants to be able to go up 2 flights of stairs.
Exactly.
So it's like when somebody comes in like this, if somebody has a really out of proportion goal compared to where they're at when they come in, it's like trying to reassign a new goal with them, let them try to reorganize it. But what's something that we could look at in the next couple months that could be a reasonable goal for us, like maybe being able to walk a grocery store or being able to, go up the flight of stairs or to be able to go on a trip and fly on an airplane and navigate the airport. Like it could be something along those lines.
And we need to also remember, because you were a runner, doesn't mean that your first goal has to be running.
No.
Right? Like when I was starting in my journey, my first goal was actually to be able to get downstairs to the common floor, to have dinner with my family, and to be able to get upstairs again without having to be carried. Eventually, my goal was to be able to go outside and sit at the atrium in my condominium just so I could get some sunlight without having to have someone push me on a wheelchair. Then eventually was to be able to go into Publix, in and out with something small. And then eventually Publix became Target and Target became IKEA.
IKEA killed me the last time I went to IKEA.
Yeah, IKEA is huge.
Yeah. Let's move on a little bit. And this is where basically Dr. Perretto offers wonderful education and courses and is working on building a full certification for this. It's quite a novel field inside of rehabilitation. As you heard, like the classification system 2017, and we had COVID in the middle of that. So, I mean, it's really, there's just not the level of education we have. But I can guarantee you that people that are learning to apply what Marcia is talking about are going to have a lot more success in working with clients that are dealing with this hypermobility spectrum. And maybe, Marcia, talk a little bit just a little bit looking at indications and precautions.
So indications, we need to remember that we need to look at the other comorbidities first. Hypermobile Ehlers-Danlos syndrome is one diagnosis. If they come in with postural orthostatic tachycardia syndrome or one of the other dysautonomias, you need to understand that diagnose, at least the basics of it. So if you don't know, you have to go look at what it is. And we're not going to cover it today, but you need to know the implications of that in movement.
Right.
And the movement, the implication of movement on that diagnosis. Mast cell activation syndrome, if you don't know it, you need to know what it is. If that patient has it, that changes as well. Because the intensity releases histamine. Release of histamine can cause them to have a flare of their mast cells.
More symptoms,
So more symptoms. So you need to understand all those things. So indications, what is appropriate for that case? What are the diagnoses the patient presents? What are the things you can use? But essentially is use tempo control for everything that you work with. Slow and regular, predictable. Add some low impact activities for the most of it. Sometimes, and I like to say it all the time, sometimes the setup of the exercise is the exercise. I can't stress how many times I say this, because sometimes you're just setting up the person, getting them to engage the muscles, get in position. And for them, this is like, oh my God, this is huge. I cannot even keep this together. So understanding that setting up an exercise can be the exercise. Precautions, do not add heavy loads at end range ever, not even in an advanced patient. Do not do aggressive stretching or have them to work in extended limbs. Avoid high impact plyometrics even later on. Some of us will never get to those. To those exercises, right?
I think that's such good advice in the precaution of it, because if you understand the tissue deformation of high load and end of range, you just wouldn't do it in anybody's program. And this is where a patient that wants to be doing that type of activity is where they really need to have the consulting and the education of like, let's find another, there's plenty of activities you can do and have joy and find that aren't going to take you to an end of range with high impact or load on those tissues. It's only going to result in another spiral and, potentially never getting back out of. You have enough of those things that take you down that rabbit hole, it's very hard to get back out of it. And so it's like the earlier we can create that education, the better. Do you have, I was going to ask you if you have an example of somebody that you sort of taken from A to Z in this that you could share briefly with the audience.
So from our case studies, you mean? So we have had a couple cases, like we have had one case with hypermobile Ehlers-Danlos syndrome, POTS, postural orthostatic tachycardia syndrome, and gastroparesis.
What's the manifestation, just for the audience, like POTS? POTS, this is where they get lightheaded and faint when they stand up fast, right?
So the definition of POTS, postural orthostatic tachycardia syndrome, means when you stand up, you become orthostatic, your heart rate, tachycardia, will increase by at least 30 beats almost immediately. So your blood pulls down because your veins are too lax. You don't have enough muscles there to protect it, to create some compression, like a compression garment, right?
Yeah.
And your heart rate...
The muscle pump's not there.
Exactly. Your heart rate increases at least by 30. I would go, my heart rate resting was about 90 back then. A lot of the patients that walk in here, sometimes they're at 100 on a resting heart rate. So when they stand up, they go to 170 sometimes.
Wow.
So they will feel immediately dizzy. They will feel the eyes get dark and close in. They're going to grab for something to try to prevent themselves from falling. Some people might go a little limp and you catch them and you just sit them, but they never lose conscious. Blood pressure will drop minimally or nothing. There is no change, or if there is a minimal change in blood pressure. That will be, and then obviously there are other systemic issues that come with POTS. That will be, they can get clammy hands, like they're always sweating. Right? Some people are just always, their palms are very, very wet. Others don't sweat at all. at all. They're going to say, oh, I can't go be outside. I will never sweat. They have heat intolerance. So remember, because that's an autonomic disorder, right? So dysautonomia is a disorder of the autonomic nervous system. That means that center that controls your heartbeat, your respirations,
The hypothalamus,
your
yeah.
sweating, exactly. So you're going to see that presentation. So this patient had hypermobile Ehlers-Danlos syndrome with all the things that collagen can affect. POTS, she could not stand for 2 or 3 minutes without dizziness. And then gastroparesis, which means her digestive system
Stopped.
super slow, almost to stop. She was able to eat, but it was very limited diet, right? She avoided exercise for 2 years due to fear of worsening symptoms. She had a limited nutrient intake from the poor digestion. And then she had a lot of fatigue and muscle wasting. Remember, as we don't use the muscles, they atrophy. And the worst part, we get sarcopenia, which is that marbleization, the marble look, that steak that looks like a marble when you go to pick up at the store. That's how the muscle becomes, the fat tissue infiltration within the muscle fiber. The less you do, the worse it gets. The worse it gets, the more your amygdala kicks in and say, don't do anything because it's dangerous, right? So the cardiologist we brought in a cardiologist. In the case, the cardiologist felt like she didn't need any medication. I always make sure I have a cardiologist that is excellent. I have a couple in different parts of the country, but she was local. We put her on compression garments from top to bottom. We increase her salt and fluid plan, because if you don't increase electrolytes, only increase water, you actually dissolve completely the electrolytes. So instead, helping it backfires. And then her GI and her nutritionist, dietitian adjusted the diet to certain nutrients and things. And then it became smaller, more frequent meals to maintain her nutrition level. Movement began like normally more so with about 5 minutes on recumbent bike. We use a rate of perceived exertion about 3, so it's easy, somewhat easy. And we work with her on paired with diaphragmatic breathing. We had her do compression boots 3 times a week. She was doing her cardio exercises, which is, I modified one of the famous protocols for POTS because it was designed for POTS, but not for EDS. So I got that program and I modified and I chopped the program in a much smaller version to fit patients that are extremely deconditioned because the program started too long, too big, too much time on the bike, right? If she only could handle 5 minutes, that program starts at 28 minutes. And then she had a specific exercise that were pumping mechanism exercises along with the stability program or the stage 1 program for the EDS. And then with proprioceptive support, obviously, she would wear compression socks or sleeves during training. And we have a specific pair of pants that we like a lot that we have them use. Long story short, her result after 6 months, she was able to do 30 minutes upright cycling without dizziness. She was able to cook, to do laundry, to walk to a local store without symptoms. Obviously, she needed cooling towels. The heat was still an issue, but her confidence in movement returned. She was no longer afraid of leaving the house because she would have what they call POTS flares, right?
Right.
So if you graded predictable cardio programs specifically designed
they can
for
apply
that
it
patient,
wherever they are. Yeah.
Exactly. With the stabilization of the autonomic nervous system, you can rebuild physical tolerance and make the person to trust their body again.
Yeah. I mean, it's like I had that experience recently just for myself of getting to where I know that I can do 10,000 steps a day. And so it gave me the confidence of knowing that I could handle certain airports, I could handle certain other events without, having the fear of not getting stuck somewhere and not having the strength in the leg to get me out of it. So there is a real psychological factor in having something you consistently are able to hit and do. Let's talk about last thing before we close down this discussion is removing the fear. Let's do a little summary of this. Like these are all, I'm so happy that you focus a lot on, staging these gentle progressions, creating these positive experiences, and respecting the fact of how the amygdala, how the sympathetic nervous system responds to these type of symptoms that they're having that only make it worse. And you've shown some really good ways of predictable movement, graded load, successful movement experiences, patient education, and getting them to where we're having success stories. You're having people that are coming in that probably have lost hope because they've been through so many hoops in our medical system. And now all of a sudden, they're, like you said, they are returning to life, are being able to participate in their world again. And you went through this on your own, but helping others to go through that there is hope for people that are being diagnosed with Ehlers-Danlos.
Yes, there is definitely hope. There is definitely hope. I think when with care and with a gentle approach and with acknowledging that person and validating their symptoms, just by that, we can give them some sense of comfort and some sense that they now have some hope. When we start working with them, the proper safety cues, you can get to dial down that amygdala, and they start noticing that they're getting, even if it's small success, even if you added a minute on your cycling, on your 2 repetitions on your exercise, it will increase your dopamine.
Yeah.
It will reinforce the movement. It will be a predictable, anything that's predictable, the body will adapt.
I love that. That's
Right?
going to be a new word that I use in some of my training. I'm going to steal it from you, Marcia,
But
which
you
is
can still
predictable.
have it.
Predictable, like create the predictable movements, especially for
Exactly.
people in chronic pain. That's so
The thing
good.
is that the same brain that learned to fear can relearn to trust.
Yeah, yeah,
But it only happens through graded action.
yeah. And this is neuroplasticity. I mean, this is
This is
and this
neuroplasticity
is also
101.
where we know that sleeping at night is the best place that neuroplasticity happens. So, we start talking about things like sleep behavior for these patients. We talk about the nutrition. We look at all the comorbidities that are accompanying it. And I love the fact that, you're looking at a team that is needed to be able to work with these complex scenarios, but in a very successful and simple way. It's like, let's make sure that they can sleep. Let's make sure that they can digest food. Let's make sure that they're having these successful experiences on a daily basis. And this is one of the things I'm adamant about, is even having a little successful experience every day is going to be better for the long term than, going out, we're doing something amazing. I've done this before. And then being out of commission for a week and then doing it again on the next weekend, like the weekend warrior, doesn't do anybody any good. It doesn't have a good ending.
No, because you know you're gonna injure yourself, right? Fear is essentially our nervous system's way of protecting you. But if you really combine the proper medical support with the smart graded movement, you teach your brain that you're safe, and your brain feels safe, it will let your body perform, and that's how really you're gonna replace the fear with freedom.
Marcia, what's the take-home message?
The take-home message, I think the take-home message is exactly that. It's replacing fear with freedom by retraining your brain through safe movements, which will give you that resilience.
Yeah, I love it. I love
For
it.
you to achieve what you want, really.
Yeah, we're so much on the same page, Marcia. It's amazing. So good. So
It's great.
good.
I know. That's awesome.
Marcia, I'm sure there's going to be people that want to get a hold of you, and there's going to be people listening to this that would want more information. What's the best way for them to get more information from you?
Well, I do a lot of education on my Instagram. My Instagram is really, really rich. So the handle is at the_eds_PT. You can also just go into Instagram and just put my name, Marcia Perretto, 2 R's, 2 T's, in case if you don't find it, you missed one, it's going to pop my account. We are making sure to put a lot of education, not only for patients, but for clinicians as well. There is a lot of good information there. You can go to my website at www.actifypt.com. You can give us a call, and you can give us a call or email us at info@actifypt.com as well. Ask to be put in our email list, because I am doing a monthly free meeting. Everyone can join. And if you're in the email list, you're going to get the email. You're going to know when the next one is and what the topic is. And I do a little quick lecture. We talk a little. I answer a couple questions. It's just a way to, give back a little bit.
Stay connected.
Yeah.
Amazing hour.
I enjoy speaking with you. I enjoy your company.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrенtanderson.com. You can follow me on Instagram at drbrentpt. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Marcia Perretto, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.